This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is Dr. Deepak Megur, and in this video I'm going to demonstrate how to explant an foldable intraocular lens. This is an anonymous trainee surgeon who has noticed that one of the haptics is cut. This is most likely because of improper loading of the lens into the cartridge. And now he's wondering whether should it be left in place or should it be exchanged. The problem with leaving this lens there in the bag is it's not going to center well. Although it might look to be centered at present, but over the longer period of time, there are higher chances of the lens getting decentered. Better sense prevails and he calls for help, and I'm in the OR now to explant this lens. So what should be the strategies when we plan to explant this lens? Let us try to write down these points step by step. So the first thing would be the lens has to be mobilized out of the bag into the antechamber. And then my plan is to cut the lens in the antechamber into 3 pieces and then remove it through the 2.8mm incision without enlarging. Well, obviously there are other methods of explanting the lens without cutting the lens fully, but cutting the lens into smaller pieces is my preferred way. So when you're doing all these maneuvers, what can go wrong? So when you're trying to maneuver the lens out of the bag, we can damage the posterior capsule. And when trying to cut the lens in the antechamber itself, 3 critical structures can get damaged. Number 1, the rhexis can get damaged. Number 2, the posterior capsule itself can be torn. And number 3, the corneal endothelium can be traumatized because of the instrumentation and maneuvering. So we need to be mindful of all these possibilities. So creating and maintaining the space in the capsular bag and the antechamber is of paramount importance. I'm going to use cohesive OVD to create and maintain the space. I'm going to maneuver the lens out of the bag by using 2 Sinskey hooks. One Sinskey goes under the lens, gently pushes the lens out so that one of the haptics is out of the bag. And then using both the instruments, the intraocular lens is gently dialed out of the bag and into the antechamber. So if you decided to cut, orientation of the lens in the antechamber is important. So I always prefer to have the haptics on either side of the main incision so that I can cut the optic into 3 parts. That's the reason why I aligned the optic at right angle to the axis of the incision. So the chamber is being maintained by the cohesive OVD. I'm going to use the Osher's lens cutting forceps, and the second instrument to stabilize the lens and to prevent it from jumping is my Sinskey hook again. So when I'm introducing the lens cutting scissors, the mouth is closed, and as soon as it enters into the antechamber, the mouth is opened. The lens is then stabilized with the Sinskey hook. The open mouth of the scissors engages the lens. It's not possible to cut the entire lens in one go. So we're going to cut first the half the diameter of the lens and then progressively move the scissors forward, and eventually a full thickness cut in the lens is done. So now we have got 1/3 of the optic cut and 2/3 is still there. So OVD is replenished into the eye, and we want to divide the bigger 2/3 optic into 2 small pieces. Again, the Sinskey hook stabilizes the optic of the lens, and then the scissors goes in and does the cutting procedure. The first half of the lens is cut, and then progressively the entire span of the optic is cut. When the scissors is coming out, it's important to note here that I am closing the mouth of the scissors and then pulling it out. If you come out open, there is every chance that we may damage the outer or the inner lip of the incision. When entering and coming out, it's preferable to keep the mouth of the scissors closed. The chamber is refilled with OVD, and then it's time to remove each of these fragments. I'm using Daljit Singh lens holding forceps. The central smaller piece of the intraocular lens is pulled out, and then the piece on the right hand side is pulled out. It is important to note that the orientation should be such that the haptic has to be on the right hand side. This ensures that it will not tug at the incision when you pull it out. So there's a reason why orientation of the haptic is important. The lens is injected into the capsular bag. The proximal haptic is then dialed in, and now the OVD both in front and behind the lens is aspirated out. And so this was a brief demonstration of explanting the lens by cutting it into smaller pieces. The wounds are hydrated, that's it, the case is done. So that was it. Thank you for watching and hope you found this helpful.